and has done an amazing work in the clinical setting in the OR, and today is finishing with his beautiful presentation. So thanks, Rohin. Appreciate it.
Thank you, JP. That's very kind. So I'll be presenting the case with Dr. Shulis on resection of a recurrent pituitary adenoma in a patient with Cushing's disease. I'd just like to acknowledge the team first, Dr. Tachana, JP, Dr. Sampson, Dr. Donaldson, who took care of this patient. So this is an 18-year-old female with a past medical history of recurrent sinusitis and eosinophilic esophagitis. In July of 2019, she first presented to the endocrine clinic due to weight gain, acne, hirsutism, hair loss. There was some concern of PCOS versus Cushing's disease. Her MRI at the time showed a 4x4 millimeter hypoenhancement lesion on the left pituitary gland, a likely pituitary adenoma. And then Dr. Shulis, did you want to present these labs?
Yeah, so it looked like these are her salivary cortisol. So we have 3 different prongs of testing for Cushing's. She had multiple salivary cortisols, which were all elevated except for one, but that was, just one. She failed a dex suppression. Generally, you'd want your cortisol to be less than 1.8 after 1 milligram of dex. And then she had an AM/PM cortisol just to understand her ambient, cortisol levels, which were 23 and 19. And this has kind of been her course over the couple of years that she was followed. It was like around 23 for her ambient cortisols. And then ACTH was 40. And then her urinary cortisols were extremely high. They were 750, 720, 900s. And your reference range is 45 at the highest. And just to complete her evaluation, she had IGF-1 and prolactin, which were within the reference range. And then her DHEAS was 582 because you're stimulating everything from the pituitary, or ACTH, I should say. And you drive the DHEAS up as well. So that's why this was elevated as well, 582.
All right. And so in October 2019, she had an initial transsphenoidal resection of the pituitary lesion. The histopathology was positive for an ACTH stain. In August of 2020, she was doing well. She didn't have any new symptoms. Her MRI didn't show any residual tumor. She was on prednisone at the time, which was tapered off in November. And then starting in November, her ACTH started trending up. She experienced weight gain, mood swings, acne, and then she failed her dexamethasone suppression test with a cortisol of 11. In March of this year, March of 2021, she had a repeat MRI, did not show recurrence, medically managed with this new drug, orsilidrostat, which the mechanism of action is that it blocks 11-beta hydroxylase, so it blocks the production of cortisol. That was eventually up titrated to 5 milligrams BID. She did have some symptom improvement, like she didn't have any further weight gain, but her ambient cortisol levels remained around 23 to 25.
Can I make a comment about that?
Yeah, go ahead.
So there are a number of different ways that you can assay hormones. Probably the most common way is immunoassays. And then of course we can use liquid chromatography, mass spectroscopy. When you use immunoassays, many of these different precursors are very similar to each other. So our total cortisol assay picks up cortisol, but it also picks up 11-deoxycortisol. And when you use this drug, it's like putting the dam in, and so the 11-deoxycortisol backs up. So if you use an immunoassay, you may actually be reflecting both of those products. If you use a LCMS assay, you will only detect cortisol. And so that's why in the labs, you might have seen different types of cortisol ordered. And also that I was ordering 11-deoxycortisol because that tells me the drug is working because it's backing that particular hormone product up.
I see. Yeah, thank you for that comment.
Dr. Sanson, if I may ask you to please just comment on this drug that is relatively, it's a new drug for Cushing's disease, and there are some implications. If you don't mind, just briefly comment on the, advantages and, let's say, limitations and side effects associated with it. We'd appreciate that.
Yeah, so this particular drug was approved last year by the FDA. It's also approved in Europe. it works very similar to our old-fashioned meteropone. It's at the same part of that synthesis pathway. And in using this medicine, I mean, these drugs are extremely expensive, in the range of, 150 to 200,000 per year. But when a patient such as this one, she was in college at the time of this recurrence, wanting to continue on with her life, we also didn't have a target in the cella. So really wanting to relieve her of that hypercortisolism, whether that is for the long term or whether it's just to provide some relief for the patient from the ravages of high cortisol. This is one of the uses of this. So we wanted to monitor her and allow her to continue on with life until we could find a way to look at a more permanent solution. You also asked about what other hormone disadvantages there might be. Well, you push a lot of the precursors shown on this over to testosterone. So in women who are on ozolodrostat, they can actually start showing some of the signs of hyperandrogenism, and that is one of the unwanted side effects of this drug.
And just for understanding as well, like when we start patients on this medication, what is I don't know, or expectation or rates of hormonal control or symptom control, let's say, for Cushing's?
With this particular drug, there's a very wide therapeutic window. So you start at 1 to 2 milligrams, and it can be used up to almost 40. And so almost everyone in the clinical trials could be controlled as long as you continue to titrate the medication and they could tolerate the increased dose. So when you use a block approach like this, it's going to be successful. In fact, it's so successful that sometimes we have to give patients back the hydrocortisone. So we call that block and replace. We block their endogenous cortisol so that we know what levels they're going to have instead of an up and down trajectory with their levels.
Just out of
Thank you.
curiosity, are there no ACTH receptor blockers yet?
We don't have ACTH receptor blockers. What we have are a couple of mechanisms to inhibit ACTH secretion. So we have pasireotide, which is a somatostatin receptor ligand, which works in Cushing's and is approved for that. And in some cases, cabergoline, if there are dopamine receptors on the corticotroph tumor surface, can help to dampen ACTH secretion from the tumor in a subset of patients, but many times they escape from that.
Okay.
Okay, perfect. Thank you.
very much for those comments. So I'll move on to the preoperative imaging. So this is a coronal T1. You can see the pituitary stalk here. There's that 3 millimeter hypoenhancing lesion on the left side. It's abutting the cavernous sinus, but it's not invading it. And then on the T2, you can see it here, and you can see the optic apparatus is fine. It's not compressed. It's not invading into it. I don't know if you have any comments, Dr. Gupta.
Sure. Actually, it is very interesting that when I reviewed the old images, we haven't had the opportunity to put the old images here, but the old images, there was a resection along the sort of the left side of the gland and right next to the cavernous sinus. And then tumor recurred just above the resection bed in between the pituitary and the cavernous sinus. And it was and on the previous imaging, it was just a little linear area of hypoenhancement, which sort of later on grew to a more sort of a round area. And that was so. In this case, it was very hard to see on T2 weighted images because it was dark, and I mean, oftentimes pituitary adenomas can blend with the gland on T2 weighted images, and they are shown as areas of hypoenhancement. So this is one case, and in this case, you can see that the tumor is sitting just right next to the cavernous sinus, just above the site of previous resection.
Okay, and then here's a sagittal T1, and that this just shows that the optic apparatus is it's right here. So it's not invading into it, it's not compressing it. She didn't have any visual symptoms, so that's consistent. So surgical planning, the approach was that she's going to have a repeat endoscopic intranasal transsphenoidal approach. The indications was disease recurrence, and a lesion was observed on the MRI at this time. The goals, one was maximal tumor resection, two was disease and hormonal control, and three was to preserve normal pituitary function. And then here's the operative video.
Is Angela with us, Dr. Donaldson? Oh, this video, can you stop for a second?
Yeah.
I'm sorry, this was a redo. So the intranasal part of the approach had been completed. So we're gonna start in the sphenoid, so that's okay. You can go ahead and play. So basically you see here on the, I'm sorry. What you see here on this side, the previous approach, and here, stop for a moment.
Oh, geez.
It's okay, you can play the video again. Okay, so we stop there for a moment. And then, so what we have here and what we have to design, so basically this is overall the cella, all of this here. And then we have to identify this space. So this is the optic canal. This is the lateral optic carotid strut. This here is the clinoid segment of the ICA. And here is the space where we're going to have the cavernous sinus. So basically, cavernous sinus is here. Actually, it stands down here as well. But then, in order to proceed with surgery, as we were discussing the case before, we need to consider this as a cavernous sinus surgery. So we need to be able to identify this, which is the trajectory of the carotid. And then that's why we're going to be drilling and exposing the clinoid segment here and have all this exposed in this area here, which is going to be the cavernous sinus. In addition, of course, a part of the cella, so we can identify the normal gland and work on this space and this space to resect this area, which is the medial wall of the cavernous sinus. So in this approach, we plan not only to remove the lateral 1/3 of the pituitary gland, but also to remove the medial wall of the cavernous sinus and inspect the anterior space of the cavernous sinus in search of tumor. So let's go ahead. So here working with a diamond drill, you see, step by step, thinning out the bone around the carotid, cella, and, paraclival region. After that's done, we can mobilize the bone tumor away with a 1mm calcium monger. With a double ball probe, you can mobilize the tumor and expose the clinoid segment of the ICA, which is the most anterior segment of the ICA. And then we can go ahead and remove with the classic, technique of a Kerrison, the bone above the cella. Basically, after that's completed, we can go ahead and continue with this exposure more laterally to further expose the carotid. So we need to have a full exposure of the clinoidal segment. And this inferior aspect here is the safe entry zone, so to say, for the cavernous sinus. That's where you usually have the bigger venous pocket to enter into the anterior region of the cavernous sinus. So here that's progressive drilling and drilling and drilling. So it's always a bit counterintuitive because we always think, okay, it's just here, that's all you need. No, you need to have this area. You need to have this inferior area, just like it's shown here in the video now. So we need to always open this inferior lateral region to the cella. And you see that being completed there. Stop, please. And then that allows us to identify the carotid, which is here, the cavernous sinus anterior wall, which is here. It's all of this, and this is the dura covering the gland. So this is going to be, you're going to see, we're going to use the Doppler. The Doppler is here right now. This is the Doppler, and we're going to be working medial to the carotid and lateral to the gland. And there's a space right here, so right adjacent to the carotid to open the wall of the cavernous sinus. Go ahead, please. So this is mapping the carotid with the Doppler. Okay, then it's after that we can open with a Seiko knife the anterior wall of the cavernous sinus, and just like in the movie, there will be blood. So we know there will be blood. So using a McAlvin knife, feather blade, we can open the wall. We gotta have a wide open so you can control that with flow seal. So you're gonna see in a second that as we open that anterior wall, we're gonna have venous oozing. There you go, and you just put your suction there, and we're gonna open that space a bit more with a straight dissector. And after doing that, we can pack it with flow seal in a moment. We just wanted to open a bit more. Yeah, there you go, more blood. And then we flow seal your packet. Good. And then so it's always a combination of counter hemostatics, warm irrigation, elevation of the bed, the head of the bed, and then you can go ahead and start cutting the inferior lateral aspect. So inferior lateral to the medial wall, that's completed there. And then as we go backwards, we're gonna have to be careful with the inferior hypophyseal artery. So the video is a bit dark there, but here in that aspect right there, we had the inferior hypophyseal artery, and then you coagulate and transect that artery so to avoid an avulsion of the artery at its origin in the meningohypophyseal trunk. And as we cut, we're gonna move backwards towards the posterior clinoid. So we still here, still mobilizing the medial wall away. And for now, we're just feeling the tissue in the medial wall right there already. So you can see that more clearly now, some of the ligaments right there.
And just, can you comment on, for the resonance, the ligaments, the inferior parastellar and the
sure,
yeah.
I think you're muted.
Stop the video. Sorry. I'm sorry. Just going back to Dr. Chaichana's point, yeah. So when you go from front to, I mean, not from front to back, I mean, anywhere within the sinus, but using this technique, which is the front to back technique, because we also can go from, inferior to superior, medial to lateral. You open the anterior wall as a first step, and then when you go into that inferior lateral space, the first ligament that you have, it's a thin ligament that is present in over 50 to 75% of people. That is the inferior parastellar ligament. That is going to be the first, let's say, blocking the road until you go backwards. After you transect that ligament, you're going to have the next let's say, blocking the road, which is the inferior hypophyseal artery. So the first cut is usually safe. The second cut in the bottom, you have to be more careful, the inferior hypophyseal. As you move upwards towards the, I'm just going to put an arrow here. When you move upwards towards the so-called proximal dura ring, we're going to have a space that is open in this medial aspect. So the proximal dura ring, this is the distal dura ring here, and the proximal dura ring runs in this direction. This medial space is always open, so there is always venous blood from the cavernous sinus going into this area that is called the clinoid segment. So in between this area, so this ring is not completely closed, but there is a ligament here most of the time. This is the so-called carotid clinoidal ligament. And this ligament is the one that, just a technical one, you see that we're working with a feather blade, just mobilizing in this direction. This is the ligament that sometimes is thick enough that we have to use a scissor to cut it and to avoid a vascular injury. So those are the two most important ligaments for this specific technique. Very important point that Dr. Chaichana brings. Thanks, Kai. And you see, once again, like the bipolars that we use here are extremely important to be able to coagulate that properly. So after we finish with the medial, with the cavernous sinus component, here we're going into the sella and cutting the dura in front of the gland, trying to preserve the plan with the gland and to be able to mobilize that. And you're going to see that that's going to allow us to get the lateral third of the gland and to resect that and to fully isolate the medial wall of the cavernous sinus. So you see dissecting that medial wall, and that's the gland here. So we got the gland there. So we got the gland. And there you go, ta, 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 ta. And we cut the gland and try to see, right, with the, as in many cases of Cushing's, we try to get tissue, we try to be, to see something that would be different. Hard to say. You see that here, kind of everything seems a bit more fibrous. So we get and send all the tissue as possible. So to see if something would be ACTH positive. And so we try to even avoid using the aspirator, kind of like trying to go and remove and actually provide tissue for analysis. And so we remove this aspect of the gland. And here we got the medial wall right here, as you can see. So that medial wall has been isolated now. And we're just going backwards. But as every time we go backwards in the posterior aspect, got to be careful with the posterior pituitary gland so we don't cause, diabetes insipidus on this patient. So now we have medial aspect, lateral aspect, and we got the medial wall right here, completely isolated. So what we're gonna have to do now is, you see, just working on the back part to see, okay, maybe some more inferior hypophyseal, some more vessels. Let's transect that, let's coagulate. And there you see the medial wall is completely isolated. And here you see like a technical problem. The scissor was not cutting, so I had to change scissors. And I had to use we had to use a bit of an angulated scissors. You see a different scissor now, and that one is cutting. So I'm gonna get that there, and this is the medial wall isolated, and you're gonna cut the up part. So this is the up part connection with the roof, and the bottom part you saw just now, and we're gonna remove that. And we do it carefully because we want to see if some of that tissue would be positive for ACTH as well, as it is in some, in some circumstances, although we didn't see anything that was clear tumor. And then you see, can you stop right there? Yeah, stop, perfect. So you see here, gland, the medial and lateral right third. The lateral third was removed here. So you see here the diaphragma, the attachment of the medial wall to the diaphragma and roof of the cavernous sinus, and this would be the roof of the cavernous sinus here. So we're looking from bottom up to identify all of that and to try to, see if anything would be present. Go ahead, please. And it's really like looking in all the corners and, I trying to identify and try to see if there is something more in the posterior part of the gland, but then you have to be careful with the posterior gland not to cause pituitary dysfunction, not to cause diabetes insipidus. And it's really easy to get, stop right there, stop right there, stop right there, stop right there, right there, go. Okay, so here you see once again the attachment of the medial wall to the roof. This is diaphragma, this is the roof of the cavernous sinus. And this is there that we were inspecting. Like we didn't see any tissue. We were wondering maybe some infiltration, maybe something. And we decided, okay, let's not resect the roof of the cavernous sinus to avoid, and avoid like a major CSF leak here. Because of course that requires a different reconstruction, but this was the one area that we were kind of like looking. But I think I agree. I think just dura in the roof of the cavernous sinus. We can play. And then the closure, we just put some gel foam. We put some glue there just to, kind of close that space in the cav sign as well. And we had no leak in this case, and then just, some biodesign. And a second layer of biodesign after that. And that was it. Perfect.
All right. Thank you, JP.
You're welcome.
All right, so a little bit of disease background. There's two papers I wanted to highlight and tie in. The first was just kind of a general review on recurrent pituitary adenomas by Hayhurst et al. So they said the indications for revision surgery are prior subtotal resections with ongoing mass effect on the optic apparatus, persistently elevated hormonal levels, recurrent tumors approaching the optic apparatus, and regrowth after prior radiotherapy, also adenoma reduction to facilitate effective radiotherapy. current management guidelines for recurrent adenomas, get a dedicated pituitary surgeon's opinion prior to any adjuvant therapy, management with the multidisciplinary team, repeat resection for symptomatic recurrent or residual tumors, and they recommend radiotherapy for residual tumors and serial imaging. And second paper was by this group, Dr. Sampson, Jachana, JP, and Carlos, treatment of recurrent persistent Cushing's disease after first transsphenoidal surgery. It was a meta-analysis. So they looked at close to 1,000 patients, and 669, about 67% of patients underwent repeat transsphenoidal resection, while 320, about 32%, underwent stereotactic radiosurgery. The remission rate for Cushing's disease was 59% in the transsphenoidal surgery group and 74% in the stereotactic radiosurgery group. And while this was higher, they found no statistical significance between the remission rates for the two different approaches. So they concluded that either treatment option is a viable option. And here's the histopathology from our patient. I don't know if Dr. Gentoff is online and would want to comment.
Yes, I'm here. Sorry, I had some lines on here. I don't think they ended up transferring. If you see here on the right-hand side, you can see this green marker that I marked before this slide had been scanned. This was prior to us doing digital pathology. You can see just below that green marker and above that you can see a very nice nested reticulin pattern. Below it is about a half a millimeter by 1.5 millimeters of an area that looks to have somewhat disrupted reticulin architecture. On the left-hand side, on the H&E, it is a somewhat more monotonous cell population. However, this was from the frozen section slide, and when you freeze pituitary, it adds a certain amount of artifact in it. On the there was more that was sent for permanent section, but that was all anterior pituitary. But you can get a sense of, you know, if you compare where I was showing you that lower part, you can get a sense that it's more monotonous, and you can get a subtle sense of sort of a nested architecture. Since it's been frozen, we don't see the sort of 3 cell types as easily as you normally would, or as we'll see in the next case. So if we go down, so if we notice that lower part is positive for ACTH, albeit a little bit weaker, and you can see the upper part has just scattered cells. So it looks like this lower part is fairly monotonous. It's not the best staining, I'll be honest with you. But it does look like we likely do have adenoma there. The CAM 5.2 is staining very nicely. Now, CAM 5.2 can stain several different things in pituitary adenomas. The most important thing in corticotrophs is what we call Crooks-Hyland change, or Crooks cell adenoma. Now, you know this, notice this dense staining above in the anterior pituitary, and it's scattered. Anytime you have an elevated level of cortisol, whether it's exogenous or endogenous, the normal corticotrophs in the anterior pituitary may develop Crooks-Hyland change. That's not a sign of anything being aggressive. But if you have Crooks-Hyland change within an adenoma, those oftentimes have a more aggressive behavior, and it's good to note. So if we go to the next slide, this is a higher power of the area that I favor as adenoma. When I say favor adenoma, we're talking about a very, very small fragment, and it's difficult to be definitive, but I really do think that it is adenoma. And you can see some of these cells have a very dense ring around them. Now that is called Crooks-Hyland change. Unfortunately, you do see cells in the background that don't have that. If every single cell had that, I would have no problem saying, yes, this is probably a Crooks cell adenoma small fragment, but I can't be definitive that some of those cells aren't admixed with other different types of pituitary cells. And unfortunately, the number of sections that we had where we had this disruption were too small to perform all of the hormones. I had to be very selective on the stains that I could perform. I basically, what I did is I leveled through much of this block, cutting an H&E, a reticulin stain, which helps tell me if there might be adenoma there, and then several unstained slides, and then another H&E reticulin, several unstained slides. And it was only one series of those where I picked this abnormality up. So if you go to the diagnosis, oh, you had it up there already. Sorry.
Yeah. Sorry.
Predominantly anterior pituitary with focus suggestive of an edge of a corticotroph adenoma. So if we go to the current case, we can see that we have 3 cell population on the left. It looks like the picture shrunk a little bit when it was center converted, but you get an idea that that is not a monotonous cell population. We have a mixture of the 3 cell types. You get an idea with the reticulin on the right-hand side that it's completely nested. We don't have that disruption like we saw in the previous case. If we go down, I'll show you the 3 transcription factors. So we have a mixture of the 3 transcription factors. In fact, we have a predominance of PIT1. If it were corticotroph adenoma, you would have positivity for T-PIT. So at the end of the day, this was anterior pituitary gland. Now, you saw how small that area of disruption was that I really think was adenoma in the first case. And, you know, whether it is macroscopic sampling or microscopic sampling, the adenoma may have been removed. It may have been very small, and we may not have sampled it adequately. In other words, you know, when we cut through the tissue, it's a few millimeters of tissue, and we're only looking at 4 micron slides. Granted, we cut through it, but even with the tissue handling, whether it's in the OR or whether it's in the pathology lab, you may have the adenoma scrape off. It is much more, it's not as firm as the anterior pituitary gland, and you could have artifactually lost that. So with any of these cases, even if you have just anterior pituitary tissue, it's important to follow the labs because you may have a biochemical response. The surgery still may have been successful, even if I tell you, well, all I can say is I see anterior pituitary tissue.
All right, thank you, Dr. Gentile. And then here are the imaging outcomes. And then you can see, the stock there, pituitary there. There's no more hypoenhancing lesion on the left. I don't know if you want to comment on this, Dr. Gupta.
Sort of question and a comment. So if you just keep scrolling, I'll tell you what slice I'm interested in. So just keep gently. Yeah, I mean, the one that just went by. Yeah, here. So I mean, clearly we can see a sort of a surgical bed here, and then just to the left of it, there is a very faint area. And on the T2, it looks like that it was part of the surgical bed. On T1, it is harder to tell. And I do have a little bit of a question anatomically, but I think surgically you can tell me much better because you were there to tell me, did you go sort of along the cavernous sinus to that area where it seems like, and I can't tell for sure, on T2, it seemed like that it may be the part of the surgical bed and something in the surgical bed. So it was a little sort of difficult to tell on imaging, if not we have a residual, or if this part which is seeing right next to this non-enhancing sort of this area of this, and is there any sort of a residual tissue there? And of course, post-operative sort of hormonal assay are going to tell us what's going on. So it's a little bit difficult on imaging to be 100% certain.
Yeah, that's a very good point, and I had looked at that as well myself, and that's kind of like put together with that image that I showed in the last aspect on the roof of the kind of towards the roof of the calf sinus was the image that kind of like gave us some pause there. I'm not sure if that could be, for example, like the gel phone that we placed at the end as well, and then played in a role there, considering that we were right at the carotid in that area. So that's the only thing that gives me a bit of pause. but yeah, it's hard to tell for sure. I mean, I can tell that my impression was that in the surgery was that we had this area here, exposed and checked with the endoscope, and also that we had this area here visualized. So, but that's why I'm a bit surprised with this. Of course, nothing is impossible. And also that we placed that gel phone with glue here, and this is a post-op day 1 scan. So I just wonder if this could be, some of that gel phone there. But
The proof is going to be in the hormones, right? We're
yeah,
about to
absolutely.
hear where we
Yeah.
stand.
Yeah, let's see. All right, so clinical outcomes. She did have a small intraoperative CSF leak. She was managed in the ICU with a multidisciplinary team. Her post-op course was uneventful. She was discharged on post-op day 2. At 3-week follow-up, she was doing well. She didn't have any new symptoms, no signs of a CSF leak. And here are her post-op cortisol levels.
So her post-op day 1 cortisol was 31, and then in the afternoon 32, and post-op day 2 is 28. But post-op day 15, her cortisol level was 9.2, which hasn't been seen for her for years now, since being on since having her recurrence. So we were talking about how she had this delay in drop of her cortisol level, and it was possibly due to a stress response that she had, because I mean, obviously she had a big surgery, and then also there's a possibility that maybe she just had more tumor cells die off throughout the next couple of days, and then post-op day 15, when we got a lab, her cortisol was 9.2 again. So we said that this was a very positive response at this point.
I wonder if you guys may comment, because I remember this case very well. And right when we finished surgery, I was talking to Dr. Chaichana, and I was talking with the team here that there were orders for hydrocortisone, and so, and then I saw, oh, it's because the patient was taking this new medication, or lisostrat. So I wonder if you and Dr. Sanson as well can comment on the post-operative management on patients that were taking that medication, just because I know that this one was taking hydrocortisone for a period of time, and so on and so forth.
So the data we have on remission and Cushing's comes from patients that have hypercortisolism prior to surgery. So you see that nice drop in cortisol and ACTH. When patients are on drugs such as osilodrostat, they no longer have suppression of their native corticotrophs, their healthy corticotrophs. So when you do a surgery, and you do a very successful one, as you did here, we unfortunately don't see that drop post-op, and we're not really sure what direction the patient is going to go in. With regard to the hydrocortisone drop, the patient from her first surgery had a lot of reactions to having hypo or relative hypocortisolism, including vomiting and nausea. And because we can monitor later, we decided to cover in case she dropped overnight. She was very late out of the OR that day. There was a lot of work going on, and just in the thoughts about safety in her particular case were to cover her in case she did drop, and she'd had this previous drug on board, osilodrostat.
I see. So basically, just because of all the specific nuances in this case, in this new medication, like when we look at the post-op day 15, the results, I agree, they look quite promising for this patient. Is that the impression as well, Dr. Sanson, or what is the impression of you and team right now in terms of next steps for her?
I think this is the best cortisol we've ever seen from her, except when she went into remission after the first surgery. But because of the past medical therapy, I probably have to do some real Cushing's tests on her, do a DEX suppression test, make sure she's suppressible, do a midnight salivary cortisol to know for sure. And I actually see her next week, so we can arrange those tests.
I see. So I
And
guess,
Susan,
I'm sorry, Dr. Q, please go ahead.
no, I was going to say, Susan, how many surgeries has this patient? This is surgery number
2.
All right, good. Beautiful, thank you. Susan, do you want to wrap it up, the teaching pearls for the residents and the fellows from today, from the first and second case?
Well, I think the teaching pearls with both of these cases is we are often never so lucky as to see unsuppressible cortisol, a high midnight cortisol, and an elevated urine-free cortisol. Often the cases are much more subtler than that, and we have to really think as a team about whether or not the patient truly has Cushing's. But both of these cases illustrated that kind of trifecta of positive testing, which makes us confident that they have Cushing's. Yeah.
Beautiful. Thank you, Dr. Sampson. This is absolutely fantastic. And thank you, Andrea, for putting the slides. That's going to be next Monday. You know, I saw that actually the presenters, Andrea Tamendi, she's going to be talking about colocysts. These are the AANS presentations that we have, all right? These are the oral presentations, Olu. Is that what we're having at the AANS?
Yes, yes, sir.
All right, very good.
Yeah.
Go ahead, Andrea. You were going to say something.
Yes, Andres, Olu, and I are going to present our accepted work at the AANS Congress.
Beautiful. Well, we're gonna. Why is it Olu looks so buff? That picture, is that like a new picture that he just recently got after he's been in research for 2 years?
That's before research, before I started working out again.
Yeah, you're looking good, Olu. Thank you. No, thank you. All of you. Everybody's doing amazing work, and I'm just so excited. And thank you, Dr. Sampson. I saw Gabriel. Let me just ask Gabriel, any last pearls from your side, all the way from Colombia?
No, it was excellent cases, and I learned a lot from all of the presentation, especially the teaching points of JP and the MRI's findings. So thank you very much. Nice cases.
Beautiful. Well, thanks, everybody. You guys have a wonderful, wonderful weekend, and join us Monday. All right? Take care.
Bye-bye, everybody.
Bye-bye.